Good morning, everybody, and welcome back. I'm Justin Mauger. I serve as the Central and Eastern Washington Community Health Educator for the Washington Poison Center. Thanks and welcome back again. I'm glad you made it today. It's our pleasure to host you. Quick housekeeping reminder, this series runs with new speakers and topics every Tuesday this month. We still have tickets available, so please don't hesitate to invite your colleagues, friends, family members, neighbors, anyone you think who will appreciate the content of this series. Big thank you to our sponsors and partners. We work for Health Washington, the Washington State Department of Health Drug User Health Program, as well as the Teen Health Hub, and the Washington State Healthcare Authority and the Friends for Life program. This is our first year at opening the series to sponsors, so we really do appreciate our early adopters and supporters here. Additionally, as participants who are tuning in, you are muted, so please direct questions and comments to our chat box. There's a chat on Whova and Zoom and Q&A. Use whichever one you're most comfortable with. I'll be checking them all, and towards the end of the presentation, we will have some time for Q&A. Finally, if you want a certificate of attendance, you'll need to take a survey that will be emailed to you from Whova at the end of the series. Last, it's my pleasure to introduce Liz Wolkin, who is presenting on revisiting overdose prevention. Liz Wolkin is a registered nurse with a background in harm reduction and emergency nursing. They currently work at the Healthcare Authority managing Scala Northwest, the Washington State Acute Care MOUD Bridge Program. Liz, thank you so much for joining us today, and over to you.
Yeah, thank you so much for having me. And hi, everyone. Yeah, I'm really glad to be here. And I want to talk a little bit today about how we approach overdose prevention and kind of talking a little bit about preventing overdose deaths and preventing non-fatal overdoses as well. We'll review some of the tools that we pick up every time and talk about new strategies and conversations that we could have to keep people safer. And so for background, overdose is the leading cause of death for Americans between the ages of 18 and 44. And drug overdose deaths have gone down, right? So there were fewer last year than there were the year before. And that's so important. And I also just want to take the time to recognize that that is still just, 87,000 drug overdose deaths is devastating. Um, those are lives, those are loved ones. And while numbers are going down, and I hope that they continue to, I think recognizing that they're still higher than they were before the COVID-19 pandemic, which was a time of very high risk. I just want to take that minute to recognize how sad and how hard the reality is. And so during that time frame where there was a significant decrease in overdose deaths, there was the decrease in emergency department visits for non-fatal overdoses was less significant. So there is a separation, there's a distinction between overdose deaths and non-fatal overdoses, and non-fatal overdose numbers are not trending down at the same rate. Also, Washington State during that time period reported the highest number of emergency department visits out of the 46 states participating for a non-fatal overdose. We have really high numbers of non-fatal overdose encounters with the emergency department, which won't represent all non-fatal overdoses, but does indicate that we have many incidents of non-fatal overdose related to or compared to overdose death. When we talk about overdose prevention, so a lot of the times what we might be talking about is preventing overdose death, which is really valuable. And one of the primary ways that we do that is with naloxone. So naloxone reverses an overdose once it has occurred. And naloxone distribution and education around naloxone is one of our primary strategies. Other things that are often go-tos in terms of education and intervention for reducing overdose deaths and preventing overdose are safer use strategies. So ways that people can consume drugs that are less likely to cause harm. Another really effective strategy are safer drug consumption sites. So places that people can go where there's access to resources and where they can consume drugs in a place that has the things that they would need to intervene in an overdose, as well as provide other risk reduction materials, strategies, and education. And we'll talk a little bit too about the Never Use Alone hotline, which is a telephone resource that people can use to activate an EMS response in the event of an overdose. And so these are kind of the go-tos, right? Like if you are having a conversation with a client, with a patient, with a friend, if you are reading about information to learn more for yourself about how to keep yourself safe. So a lot of the things that we're going to see over and over again recommended to people. And they're the ones that I've been doing harm reduction stuff and drug user health stuff for a really long time. And when I was a kid and doing peer-to-peer exchange, and starting to learn about these things, this is always like the go-to as safer use strategies and naloxone distribution. So in Washington State, there's pretty widespread access to naloxone. It is available over the counter, but it's not inexpensive, right? So over the counter does mean that someone's paying for it out of pocket. You can also get a prescription for it if you don't have like an encounter with a healthcare provider that leads to a prescription. Washington State does have a statewide standing order, so anyone can use their health insurance to get naloxone from a pharmacy. We also have laws that require it to be dispensed from behavioral health agencies and emergency departments, and you can get it at syringe service and drug user health programs. But one thing that's really important to note about naloxone distribution is you can't self-administer it. So this is an intervention that requires other people. It's an intervention that happens after an overdose has taken place. And it's one that having naloxone alone won't be enough if you're not sharing information and educating folks around where it is, when to use it, how to use it for the people around you, especially if they are loved ones who may not be using substances or have had that experience having reversed an overdose before. And then we have all the safer use strategies. And I think one of the most important ones to note is that accurate and unbiased information. So making sure that like people have the education and the information that they need to make informed choices and to make safer choices. Access to safer supplies. Source consistency is a big one. There's increased upticks in overdoses after DEA raids or police confiscation, and changes in the drug supply. And so if you can have a consistent source or one that you're used to, and drug testing, knowing what's in your drugs, right? Making sure that you start low and go slow, and you can do small doses or space them out, right? So give yourself some time in between use to see, how is this impacting me? How potent is this dose? Staggering use if you're in a group, so you can have one person use, wait a little bit for the next one, making sure that there's someone who's alert or available if anyone does overdose. And then taking precautions when using alone, telling people where you are, telling people you'll be using. And these are all important strategies, and many of them can't be regularly accessed. Like these aren't all in someone's control, right? They're not all in someone's control every time. They are great. And I think it's really important for us to recognize that they are ideal and not always practical or available. Safer drug consumption sites give you the ability to have more reliable access to those safer use strategies. So why can't you space out your doses or go slow? Maybe you just don't have somewhere safe to use and to wait, right? Why can't you stagger use? Again, maybe you don't have somewhere where you can take the time to like really be able to plan through and move through the safest strategies. But in a safer drug consumption site, you are not hiding from the public, from family, you're not hiding from law enforcement. You're able to control your setting in a way that is less scary, and also able to be safer. And in the instance of an overdose, there are folks there who can intervene, who can reverse it. One of the great things about safer drug consumption sites is similar to syringe exchange programs and drug user health programs, is there's also just other services on site. And we know that folks really benefit from that, right? Including access to treatment, but also infectious disease testing, psychiatric supports. So these are really effective in terms of reducing harm. And then when those things aren't accessible, which like they're not always, there's the Never Use Alone hotline. So it's a 24/7 toll-free number. It's staffed by people with lived experience. If you are by yourself and can't let someone know what is going on or have other folks with you, then you can call them and they'll chat with you on the phone. And they are not going to try and tell anybody to stop using drugs. They're just going to hang out, get your information, like your location, so that if you stop responding, they can activate EMS for an overdose intervention. So those are kind of some of the strategies that are most commonly shared, most commonly talked about as how to prevent an overdose. And some of them prevent fatal overdoses. All of them prevent fatal overdoses or reduce your risk of one, but not all of them reduce your risk of a non-fatal overdose. And so naloxone reverses an overdose after it's happened. But one of the things that I think we can try to like really focus on and expand education and awareness around is preventing non-fatal overdoses as well. Additionally, of these options, safer drug consumption sites aren't available in Washington state. And so they're kind of, we can take them off the list of interventions that we have to prevent overdose. And so non-fatal overdose is really harmful. And I think that when we talk a lot about reversing overdoses and yes, of course, of course, let's reverse overdoses, right? Like we don't want people to die, but also I don't want them to have a near-death experience. It's scary, it's awful. People feel shame, fear. There's harm to their relationships, right? Like there people get mad at them, right? Like it's like the idea is what's wrong with you? Obviously, this means you should stop. You're obviously not being safe. It's too hard for me to stay in a relationship with you because this is so painful and I'm so scared of losing you. Increased levels of like anxiety and intrusion or withdrawal. And then there's also just opioid withdrawal. Outside of relational and emotional withdrawal, is that if a overdose is reversed with naloxone, you feel terrible and that's harmful too. Additionally, non-fatal overdoses can have negative health outcomes. So even if someone doesn't die, they could have periods of time where they didn't get enough oxygen to their brain or other physiological consequences of the non-fatal overdose. And so I think that really talking about like what harm this causes to people is important. And also, there's an elevated risk of having a fatal overdose after you've had a non-fatal one. So your risk of overdose death increases, and that continues to increase with every subsequent non-fatal overdose. So preventing a non-fatal overdose from happening is part of preventing a fatal overdose from happening as well. And so we talked about these safer use strategies, and and in addition, and so it's like, why is there an increased risk with non-fatal overdose? But besides it just being painful and harmful in and of itself, these safer use strategies are some of the things that we may use to prevent an overdose happening at all. These are not about reversing one, other than the staggering use and taking precautions when you're alone. But some of these other ones, starting low, spacing out doses, drug testing, those are intended to prevent a non-fatal overdose or fatal happening in the first place. But many of these strategies could be impacted by that non-fatal overdose. So if you are in severe withdrawal precipitated by naloxone, that ability to start low and go slow may not be there because you're needing to address your symptoms. If you or wanting to address your symptoms, whether that will work or not, but needing to try and solve this big problem, you are maybe transported by EMS and now you are somewhere else. You are not at home or you're not in the place that you usually use in and the people you usually use with. So all of a sudden, your setting has changed. Possibly your source has changed. You've also had a trauma and and it's scary, right? And so those things can make it a lot harder to engage in these safer use strategies that can prevent overdose. And so when we look at subsequent overdose prevention, when we look at having another overdose after a non-fatal one, safer use strategies, maybe harder on naloxone distribution and never use alone hotline are not necessarily going to be prevent that non-fatal overdose. They're there to reverse a fatal one, or what would otherwise be a fatal one. So, I want to talk more about what we can do, alternate responses to non-fatal overdoses. And I am going to focus pretty heavily on the role of hospitals and emergency departments. That's for a couple reasons. Uh, my personal background is that I'm an ER nurse, and so that is just where my area of expertise is. And also because these are areas that just have a really profound impact when folks go. They are sick, they are hurt, they are scared. It is not a fun place to be. And it's oftentimes the only intersection people might have with a healthcare system. It's oftentimes not a willing one, but just a matter of necessity. And I think that there's an opportunity to have a really profound impact when it comes to overdose prevention if we can shift the way that folks are cared for in hospital and emergency department environments. But I really do just want to say that overdoses are reversed every day by friends, family, and bystanders. So community administered naloxone saves lives, and the conversation that focuses on the emergency department and the hospital is not at all intended to diminish the value, frequency, or importance of those interventions, and is more reflective of kind of my background, area expertise, and the potential impact because of the resources in those settings. And it's really high risk, right? So if someone goes to the emergency department having had a non-fatal overdose, in the year following, there's a 5.5% all-cause mortality. And so um, they, that's really high. That's a really high risk of death in the following year. This is from one study. There's other studies that show that number is being higher. Um, and this distribution of deaths is disproportionate. So it's not evenly distributed over that year. 20% of the people who died did so in the first 30 days. And they were discharged and died within a month. And 67% of the overall deaths were due to an opioid-related overdose. So we have folks going to the emergency department, discharging, and then having a repeat and sometimes fatal overdose. And I think we can look here at the distribution of deaths to understand like the opportunity available in the emergency department to intervene and to recognize the impact that that setting could have on overdose prevention. So this is the first 30 days following ED discharge. So we have a high risk of death in the first year, disproportionately distributed over the first month. But now we look at the first month, and it's day one is right up there. And so people are being discharged and then dying. And that's not the role of an emergency department. The emergency department is meant to stabilize people and reduce their risk of death. So that study was a couple years ago, and it was in Massachusetts. We did an initial data pull here in Washington State. So this is claims data for Medicaid, and we see a very similar curve. So over the course of a year following an ED visit related to opioid use disorder or opioid overdose, there's a disproportionate distribution of deaths over to month one. This one has about 25% in month one, and then again leaning towards days 1 and 2. There's that indicates that there's a high likelihood that those that 67% of opioid overdose related deaths is that percentage is likely higher in those first few days because we even out after that. And it's not only emergency department visits, it's also after hospitalization. And so this curve looks really similar to the one that we just looked at. And this is the risk of overdose after being hospitalized and hospitalized for any reason, so not specific to overdose. And this includes both fatal and non-fatal overdoses, but shows a similar distribution curve of the risk following hospital or emergency discharge being really high for having an overdose. The two colors here, the orange represents before medically advised, and the blue represents physician-led discharge. And so that blue line is someone who has stayed until the physician decided that they were medically stable and cleared to leave the hospital. And the orange is someone who left before medically advised. We can see there's a much higher risk there with repeat overdose, but the curves are similar in both groups. So clearly there's an opportunity in the emergency department in the hospital to intervene and to reduce risk of overdose. So what can you do in a hospital setting? And I think the first thing is just treat withdrawal. Treat withdrawal. You don't have to worry about treating someone getting someone into long-term treatment or care or into a treatment program, right? Because they're not going to be with you that long. An emergency department visit or an encounter with pre-hospital EMS or hospitalization is a short-term thing, but that's when that risk of death is. That risk of death is in that first period of time is so high, and there's this really high risk that people are going to leave before medically advised if their withdrawal's not treated because it's very difficult to stay. And so risk of death increases leaving if you leave before medically advised, and risk of overdose specifically increases if you leave before medically advised. And treating withdrawal is the best tool to prevent before medically advised discharge and encourage a physician-led discharge, which is going to reduce risk of overdose and death. And then offer linkage to care. So treat withdrawal and offer linkage to care, because methadone and buprenorphine following a non-fatal overdose can reduce all-cause and opioid-related mortality by nearly 50%. That's for folks started in the emergency department. And what's interesting about that is we're looking at a treatment range of anywhere from 2 to 9 months. So folks who are on medication for 2 months, for 3 months, for 4 months, reduce their risk of death. It does not always have to be a long-term medication. And many people have instances or episodes of engagement in treatment, and then episodes of disengagement and episodes of re-engagement. And that's totally appropriate and will still reduce overdose risk. I'm going to touch back on opioid withdrawal. Opioid withdrawal is feels terrible, and it's treatable. And if someone is in the presence of a prescriber, if someone is in a medical setting, if they're in the emergency department, if they're in the hospital, their withdrawal can be treated, and it will make them safer, less likely to die, less likely to overdose, and feel better. And if folks do end up leaving a care setting when their pain or their withdrawal is undermanaged or unmanaged, that is not that is a result of insufficient care and not a moral failing of that individual. And so there's opportunities here to keep people safer simply by treating withdrawal and not relying on long-term treatment. And so to continue to kind of talk about this opportunity to be using medication, to be treating withdrawal, as a way to reduce risk of death and as a way to as a way to kind of address overdose risk. This here is a graph representing claims data that shows the risk of death following an emergency department visit for opioid use or opioid use disorder if someone receives MOUD versus if they don't. And the blue is folks with no treatment. So folks who did not get methadone or buprenorphine within 24 hours of that emergency department visit. And the green is folks who did. And we're really only looking at a single instance in a 24-hour window. So this doesn't look at was someone in treatment a month later or 6 months later or at a year, how many months of treatment. We're just looking at did they receive medication following that emergency department visit within 24 hours. And we can see a greater than 50% reduction in mortality at 1 year, at 1 month. But at 48 hours, we see a tenfold reduction. That's very significant. And likely that impact has to do with decreasing overdose deaths in that period, because this is all cause mortality. So they could have, so at a year, there's less of an impact because we're looking at that curve and that risk of overdose within the window immediately following an encounter with acute care. We can hope that this reduction in deaths would also translate to people leaving inpatient from the hospital when we saw a similar curve for risk of overdose following hospitalization. We could hope that this intervention would be equally impactful, reducing that risk of overdose within that 48-hour window. And I'm going to talk a little bit about the protective factors for short-term medication as well as longer-term engagement. But I want to just quickly pause um, because when we talk about MOUD as overdose prevention, when we say, hey, look at this, we gave people some medication. Like they had a non-fatal overdose. They were in the emergency department. They were at high risk of death, high risk of repeat overdose, and then they got medication and it reduced their risk. Or we had people in the hospital who had a really high overdose risk, but if they were able to stay, their overdose risk went down. And a lot of that has to do with managing withdrawal and offering MOUD. But I do want to clarify when we talk about MOUD what it is that we're focusing on. And so, one really effective medication to reduce overdose death and all cause mortality is methadone. It does treat opioid withdrawal, it reduces cravings, and it's only available in opioid treatment programs and hospitals. So, the access to it, depending on your geographic distribution and setting, isn't as reliable as buprenorphine. Buprenorphine also reduces mortality by over 50%. It also treats opioid withdrawal and reduces cravings. But additionally, and really relevant when we look at overdose prevention, is the respiratory depression ceiling. So buprenorphine only causes so much respiratory depression, and it kind of evens out at a certain point. And so people don't typically, if they have an opioid tolerance, they don't typically experience respiratory depression enough to have an overdose or to stop their breathing. And there's competitive receptor occupation. So buprenorphine binds more strongly to opioid receptors than fentanyl does. And that can allow it to prevent, than fentanyl or other opioids. And so that can allow it to prevent full access to those opioid receptors that can lead to respiratory depression and overdose death because the buprenorphine is blocking them. And while naltrexone is FDA approved as a medication for opioid use disorder, it doesn't treat withdrawal or reduce mortality. And so, what we are talking about when we're thinking about how can we reduce overdose deaths is not talking about the long-term treatment of opioid use disorder. We are instead talking about treating withdrawal to support safer use strategies and being able to stay in medical care. And we're talking about reducing the risk of death. So naltrexone isn't a part of the conversation for MOUD as overdose prevention because it just doesn't have the same evidence to support it reducing mortality. And so while methadone is truly a great medication and a safe one and an effective one and reduces death, I do want to focus a little bit on buprenorphine because of that respiratory depression ceiling and that competitive activation, and explain a little bit how buprenorphine can specifically address that high risk period following a non-fatal overdose. So if someone, so you have fentanyl in your system, right? And it fully activates your opioid receptors. So if you have, here's your fentanyl, here's your opioid receptor, fentanyl's on board and they're fully activated. You're getting the responses, right? You're getting pain relief, you're getting euphoria, your withdrawal is managed, and there may be respiratory depression, and there may be enough to cause an overdose. In that case, you can put naloxone onto the receptor and it's stronger than the fentanyl. So it'll kick the fentanyl off, come on in, but it does not activate the receptor. So it shuts it down. And all of a sudden, you don't have any receptor activation. You don't have any opioid response. You're in withdrawal. You've lost your pain management, right? And so that's why people go into really severe withdrawal when they get naloxone. Buprenorphine is stronger than naloxone. So buprenorphine will come in and it will boot off the naloxone and it'll bind to the receptor and it binds strongly and it partially activates it. So you get some of that relief. Withdrawal is treated and um, because it only partially activates, it won't go to that same level of respiratory depression as long as you're opioid tolerant that you might with a full agonist opioid or a fully activating opioid. So it can be safer and protective against overdose. So that buprenorphine can treat the withdrawal caused by naloxone, which can be a huge relief and reduce the trauma of a non-fatal overdose, both physiologically and emotionally, and in terms of the ability to respond safely for that individual. But also, if it's stronger than naloxone, it's also stronger than fentanyl, and it will hang out on those opioid receptors longer. And so, with a half-life of 24 to 48 hours, it's going to hang out on those opioid receptors and continue to provide protection against respiratory depression because it's going to continue to have bound to some of them, but only partially activate them. And so buprenorphine following a non-fatal overdose can treat both the withdrawal and it can treat the opioid use disorder. So if someone has a positive experience with that buprenorphine, um, and they decide they want to stay on it, that's great. And many, many people do decide or want to make positive change to stay safer after an overdose. And that could include not using alone, carrying naloxone, other safer use strategies, or it could include initiating longer term medications for opioid use disorder. There is also the possibility that someone could have that experience with buprenorphine and find it to be effective treating withdrawal and say, oh, I might be more open to this in the future. And we know that that will, in a longer term sense, reduce risk of overdose death. And it also just treats the withdrawal, which needs to be treated. That will allow for the care of acute and emergent medical conditions. So it will allow for the recognition of whatever underlying processes are going on, whether there was or wasn't a fatal overdose, and allow people to stay safer while they receive care. Using buprenorphine too, following a naloxone reversed overdose, can build trust in medical systems, in medication efficacy. Someone is more likely to be willing to go to the emergency department or go to the hospital if they know that they'll use medication to treat their withdrawal. And that can have wide-ranging impacts the next time someone might have an infection or sudden or severe pain and they need to get checked out, but are scared to because they may not have their withdrawal managed or their pain managed. But if they've built that trust in the medical system in a specific hospital to say, hey, actually, they did treat my withdrawal at one time, I think I could go again, then there's significant reduction in harm. Also, initiating buprenorphine, you have to be in withdrawal to start it. We talked earlier about the ways that buprenorphine binds really strongly to those opioid receptors, and it can kick naloxone off, but it can also kick fentanyl off, and it's not as strong in its activation. And so, if you do that when you are not in withdrawal, people can get sick. Um, and that can be a big barrier to initiating longer term buprenorphine treatment if that's something someone wanted. And so the opportunity to use buprenorphine when someone is already in withdrawal is potentially kind of a pathway to that. But I want to be clear that it should be offered and can be used regardless of long-term treatment plans. So I think that's really kind of the key framework shift that I'd like to encourage, or one of the key takeaways, is we think of medications for opioid use disorder as only appropriate for long-term treatment, or only able to reduce mortality if someone is on them consistently for however long. But there's these opportunities following a non-fatal overdose, following a hospital discharge to reduce short-term risk, right? Both of a repeat overdose and also just kind of psychic injury, physiological harm. And so this is something that can, like, this is an intervention that can be used regardless of those long-term plans. It's also just really hard to make decisions about long-term plans when you are in chaos or in crisis or in withdrawal. And so by being able to access medication, by being able to address some of those immediate needs, the conversation about what happens next can be a lot more effective. And probably most importantly, or very importantly, it can reduce that 24 to 48-hour risk of subsequent opioid overdose. And that is the job. That is the job for hospitals and emergency departments, is to stabilize someone for that short-term period. And it is a reasonable thing to want and to expect. And so, that is talking a lot about intersections with healthcare systems, with pre-hospital, with EMS, 911, emergency departments, hospitals. And there is some, and part of that reason is because there's prescribers, like there's access to medications, and that's not something that you can control as much at home. There's no standing order for buprenorphine the way there is for naloxone. You can't, pick it up at a um, syringe services program. But we did talk about, like a lot of those safer use strategies and other strategies, they're not always perfect. They're not always in our control. And there are some things that we can do to make buprenorphine a little bit more accessible, to consider it at home or outside of the emergency department, and to potentially reduce harm because of it. And so I think one thing is the opportunity to reach out after a non-fatal overdose is not perfect, will not get meds to you in time to treat withdrawal. But it is an opportunity where, and maybe you'll be able to access those meds, but maybe be able to just access them in time to reduce your high risk window. And you can use the UW telebuprenorphine line in King County, or soon it will be a statewide program, or there's virtual providers such as Boulder Care. So being able to have on-demand access to buprenorphine after a non-fatal overdose or other high risk like other high risk encounter, I think could be really really beneficial and something to consider. There's also the opportunity to have buprenorphine available. So you can ask for a prescription for home initiation. So if someone is not yet in withdrawal or not ready that day to start buprenorphine, there are home initiation protocols where you get a prescription from buprenorphine, and then you have it at home and you take it when you're ready. So that would mean in some withdrawal and also prepared in a bigger kind of medical personal cycle social sense. So having that prescription available, getting the home initiation prescription, filling it, and then having buprenorphine available for when or if you need it. And that could be because you're like, I am absolutely starting this permanent long-term treatment plan, or it could be because you had something that increased your risk level. You are in some withdrawal, maybe did have a reversed overdose, and you say, hey, I have this here, I have this right now. I'm gonna keep myself safer with it. And another is practice advocating for yourself and others, and this is really hard, but MIUD is not routinely offered following a non-fatal overdose or on hospital admission, and um, that is something that we can all work together to change. But one thing too is that you can ask for it. And you can encourage the people that you love and the people that you work with to ask for it. And if you are a provider, you can offer it, you can provide it. But if you're advocating for yourself or for a loved one and asking for MLUD, that shouldn't be a request that's denied unless there's a very clear clinical contraindication. So really, that is something that should result in having opioid use disorder treated and withdrawal managed. And then to say, we did again talk a lot about buprenorphine, and it might be the go-to for a lot of people, but methadone reduces all-cause and overdose death. And methadone is a wonderful and fantastic medication, and it is appropriate in the hospital or in opioid treatment program settings, and it is maybe less likely to be offered. It's not available everywhere, only in some counties and some communities, but you can ask for it. And if only buprenorphine is being offered, it is appropriate to advocate for methadone as an option, not perhaps for that 24-hour period following a non-fatal overdose, but in a longer term overdose prevention sense, um, you know, it is appropriate to advocate for methadone access as well. And so there is so much value to all of the overdose prevention strategies and education. We can prevent fatal overdoses or reduce the risk of fatal overdoses with naloxone, reduce the risk of a fatal or non-fatal overdose with safer use strategies. Um, Safe drug consumption sites will hopefully be an option for us here in Washington, and the Never Use Alone hotline is always available 24/7. Um, but I think we can add to the conversation methadone and buprenorphine because these medications reduce overdose death and they reduce risk of a non-fatal overdose. And they can be part of the conversation. We can recognize a higher level of fluidity between different places and progressions and experiences and processes where it is not either or, it is not um, drug use or abstinence or treatment, but it can be right now is a time where I would be safer with access to these medications. And that's the priority. And what happens a month from now, we will see, but we can be allowed to have the conversation about using medications for opioid use disorder as a way to reduce harm. And some references because I threw data information out there for you. And then, yeah, I want to leave time for us to answer questions and have a discussion.
Wonderful. Thank you so much. It looks like we do have a few questions in the chat. We'll just start at the top and work our way down.
Mhm.
After administration of naloxone, does the person go to the hospital or is that just a suggestion?
That depends. That depends. So, does someone always go to the hospital? No, absolutely not. Community reversed overdoses happen all the time. And people often choose not to call 911, not to go to the hospital. Even if 911 is called and EMS responds, people can decline transportation to the hospital. There are some instances where absolutely, if you're administering naloxone and someone is not responding to it well, if it is not, then clearly, immediately and emergently, an emergent, you need to call 911, right? Um, but every day, people have overdoses. They're responded to by their community members. They're reversed by their community members. And there's never an intersection, even with 911. And yeah, not all 911 hospitals transfer to the emergency department. Is there a recommendation that everyone should go? I don't know, but it's not the practice.
Okay, and then there was a follow-up question from Brenda as well. Does the 24-hour hotline provide resources as well for those that want help to stop using drugs? I believe that's in relation to Never Use Alone.
Never use alone. If someone asks for support, they do have they can offer resources, but it's not their primary role and they are a national hotline. And so I think that it's more appropriate for 24-hour access to resources here in Washington to call the Washington Recovery Helpline. They are a 24/7 line that can offer resources and support for substance use disorder and we'll be able to provide kind of local and state specific resources.
Excellent, thank you. From Garth, perhaps I misunderstood an earlier slide. An overdose involves someone who is not breathing. Under what circumstances would an overdose not be an appropriate situation for emergency medical post-care?
Well, if someone if a community member, a friend, a loved one, family member, bystander administers naloxone and reverses the overdose, and someone is now breathing, they may choose to not call 911 and not engage with emergency services. Oftentimes, people who go to the emergency department are treated badly. They often don't have their withdrawal managed. They're brought there and then just told to sit there until they're allowed to leave. There's not a lot of interventions that are typically provided. I think that if buprenorphine were regularly offered to manage the withdrawal caused by naloxone, it could be a different story. But in the current state of things, people have experiences of having EMS go, being sick, getting taken into ambulance, going to the ER, being treated poorly, and not actually getting care. So the choice to not go to the hospital or the choice to not engage with EMS makes sense for people a lot of the time. Um, Provided that the naloxone they were administered restore, that they are breathing and their respiratory depression is reversed and naloxone is an effective medication, then it is really understandable why people choose not to go.
Thank you. Uh, I like this one from Beth. If bupe binds to the receptor stronger than fentanyl, if someone uses fentanyl after receiving bupe, will the fentanyl not have any effect?
It will have less of an effect. And it depends on how long ago you used buprenorphine and at what dose. So I can't answer that the exact same way every time. But because people do use those substances, but yes, it can diminish the impact of it. It reduces the risk of respiratory depression. Again, it'll depend on your doses and how far you are out from administration for both things.
But thank you. And finally, we have one more from Eric who asks, what is Washington doing or not doing that keeps our state at the top of the list for non-overdose emergency department visits and the continuing very high number of overdose visits, even if that number is down a bit since last year?
I think that's a great question. I think it's complex and multifactorial, right? It's like there's so many different things that there's too many different things that like could be a part of that to kind of answer that question. But I think it's just continuing to make sure that there's access to all of these strategies, including medications for opioid use disorder, and that every prescriber routinely offers them, including in hospital and emergency department settings, right? Like, what can we do to make sure that people have access to medications? But in terms of, why there's just so many factors, whether it's housing, drug supply, socioeconomic status, insurance. Like, I mean, there's just I don't have an answer to that, but I think that there's room for us to continue to advocate for and expand access to medications that can help reduce overdose.
So much. This was a wonderful presentation. I really appreciate the information you shared, the perspective you offer as well. Just want to remind folks that 11:45, we have a conversation with Johnny, barriers and facilitators for Spanish speakers in Washington. We hope to see you there. Liz, thank you so much for your time today and again for sharing a great presentation. And I'll personally look forward to watching it again. So thank you.
Cool. Yeah, thank you guys so much for having me.